Testing. Oh, okay. Hello, everyone. Welcome back. We're going to get started with our final session of the conference. Amazing. This is always my personal favorite part, by the way, because this is where we try to get practical. So, I don't know about all of you, but our group definitely did not have enough time. So, all right. So, Tom Ellman has graciously agreed to moderate this session. For those of you who do not know him, he's the director of the Southern African Medical Unit, or SAMU, of MSF, based in Cape Town, and he has 25 plus years humanitarian experience. He started at the end of the genocide in Rwanda in 1995. So he has a lot of experience and is going to help us tie all of this together. So the way we're going to work this is I'll let you say a few words, Tom, but then each group will come up one by one and present maybe 5 or so minutes what you discussed. And then we're going to try and really hone in on some action items for us to move forward with. Also, you'll see, hopefully online, Emma, I believe with Ink Factory, is there. Could we see her potentially? Or anyway, Emma, hi. I can't see you, but thank you for joining us. And she'll be kind of illustrating and documenting what we're saying. So, Tom, over to you.
Thanks. I think I'm a bit of a poacher turned gamekeeper. I'm really experienced at kind of just talking around things and avoiding action points. And so I know all the tricks, and I understand the aim of this session is really that we come up with some concrete plans, concrete ideas, and I'm also meant to write some of them up on the board as we go there while you guys present. I've just been flitting around some of the groups, and I was expecting that kind of post-lunch slump that you always have, but they weren't. What was the word? Galvanized. There was a sense that people were galvanized. And I have to say that last session really drove home from me that there is potential for activism in this space. I got one of my activist-ish t-shirts that I have to put on just to remind us that there is more than just being scientists and lawyers. There is a sense of the spirit that goes with this. I don't know if any of you were at Durban 2000 AIDS conference, which was the moment when we confronted government, we confronted Manto Chabalala, who was your little vegetable in the picture there, around the prices of antiretrovirals, the denialism, and the insistence that these drugs should be made available. And I feel something of that coming around GLP-1s. Not that GLP-1s are the answer, far from it. Not that the issues are as simple, they're much more complex than HIV, in my view. But I think there is an incredible moment, and fired up. You know, we should, if this was an HIV audience, we would be saying, Viva Yada Viva! I don't know if anyone, you're all meant to go, Viva! Okay, so we're going to move to the first group, which is financing. Do we have anyone from that group? I have the feeling not everyone is in the room at the moment. Some of the groups may not have. Are all the groups here? I assume someone is going to go and whip. Okay, cool. Can everyone also think of what I should be writing? What is the key point that's coming out? Because I may miss it.
Okay, so apologies in advance if I feel like there's too much information and fragmented information that I'm going to share because there was not enough time to summarize it. So we had a lot of discussions around basically 4 key areas. The first one being whether there is money available or not. And there were, in my group, there were Austin, there was Rachel, there were James and James. Both of them, and I'm sorry I don't understand how to pronounce some of the names. Okay, anyhow. So there was discussion on whether there is any money or not, and if there is money, how can that be diverted to the NCDs and diabetes, specifically in the humanitarian settings. There was quite a lot of discussion on the need of data for planning the intervention, both in a proactive and a reactive method. So why do we need data? What quality of data is needed? Do we really need a lot of quality data for planning in a humanitarian crisis-based intervention? And how can that data be collected, etc. So, and then I'll go forward. So there was discussion around gaps in knowledge, delivery steps. So James pointed out that a framework need to be developed in a stepwise manner where we need to understand what exactly do we want to do and have a cost basis for each of those steps and how they need to be delivered. There was a discussion about the lack of clarity about funding, how funding can be accessed in a humanitarian settings. The surveillance systems came up again and again and again in the situation, for example, in Mali, in the UNRWA example, in Gaza, in the Pakistan example as well. And I'm sorry, so there was discussion about can we somehow engage with the private sector to see if some data is available from there for pre-planning for the humanitarian settings. There was discussion about what are the pieces to prioritize to be able to finance. Can WHO play a role with the member states? And sorry, I think this is all about data. There are first 4 pages about the data, and then the framework. Then we came to the framework where there are the levels and the steps, and we talked about what are the group 3 that will be the bare essential minimum service package that we need to deliver, and then is there, for example, step 2 that goes to education on switching guidelines? How do the peer networks come in? How do we ensure that the response is not fragmented? Is there a united response that can go in when there is a humanitarian crisis? There were suggestions to have a study or a pilot to understand the costs in one of the humanitarian settings. And we also discussed one important aspect we discussed was a reactive mechanism. And there was discussion about the COVID handling in Pakistan when cash-based vouchers were being given out to people who needed it. And that helped with a lot of data collection as well. So can we go into some reactive mechanisms like that? And Austin also suggested something like, can we give out cash to people who are already paying out of pocket to stop them from going into impoverished situations? But then there were also rebuttals for the same thing, that cash may not be used for the reason it is being given for. For example, it may be used for food or other necessities that are important in a humanitarian situation. So it has to be a very carefully crafted policy on whether to give cash or not, and how to monitor that it is used for the right thing. And then we also had this question raised about how to address the challenge if there is, for a reactive collection of data, how to address the challenge when, specifically in context of cases of conflict, the communication systems go down. So how will people actually collect that data and report on that to start reporting the demands for or the need for that conflict? And yes, I think that is it. Oh yes, there was another issue that was raised was, is there any kind of integration possible with infectious disease? Is there any this needs to be evaluated, whether there is any possibility of integrating infectious disease with the NCD. So do the health outcomes for people with infectious disease get worse when they have diabetes? And we all know that they do, but is there an investment case there to integrate the two interventions together for for not going into silos, but going hand in hand. Have I missed something? Rachel?
Settings to develop proposals that might be of interest at the Global Fund, and that
And there was the pooled philanthropy, something about pooled philanthropy that we talked about as well, like how can we pool the philanthropic funding towards an NCD response in the humanitarian settings. Yes, and yes, we did talk about that the center of gravity is currently, when we talk about integration with the infectious disease and NCDs, the center of gravity is currently research and not in humanitarian-based humanitarian crisis response. But there are synergies that can be built specifically when it comes to the advocates community. There's a lot of overlap, so. Yes, I think that's it. Rachel.
for people in the NCD community to develop greater capacity to work with infectious disease organizations that apply to the Global Fund for funding, that skills building and bridge building, perhaps, so that there can be a win-win opportunities that might get some funding flowing.
Anything else? Team? The group? James? Anything that I've missed? No? Okay, great. Thank you.
Thank you. We're not finished quite yet on this, though. I think we're going to need. I was trying. Maybe I did a bad job, and maybe you can't read what I've written. But I was trying to think through what the themes are here and how we turn them into. There were a lot of questions. I think, how will we do this? How will we do that? And all of those questions have action points linked to them. And what I just wanted to make sure that we capture, is there something specific, a deliverable, a time point, a responsible, an action that goes with some of these? And I wonder whether you had time. But I guess now is the time for us to try and build that. So the groups in some will only have had time to bring out some of the themes. And let's just see whether we can try and dive in a little bit on some of these. Just before I do, are there any immediate, what I'd like to do is just go through some of these points and see where is the action there. But I just wondered, was there anything else that other groups saw in there? Because I'm aware that we have a lot of expertise and experience across all the groups. Did any other groups immediately, unless you see it already here and we'll come back to it as we look at an action, any other big themes that other groups felt we need to be building actions on around financing that didn't come out there? Okay, so engaging with the private sector in order to get the finance, the pharmacy, potentially the costs that we need to raise in order to finance the response. Okay, so.
Sorry, Tom, I want to elaborate on that point to address your question. We were talking initially about the fact that people pay for their meds and supplies out of pocket a lot, and it is obviously, that's a problem. It's inequitable and impoverishing. And so what kind of mechanism can be used to help people pay in an emergency situation or humanitarian situation? And so the suggestion was made that vouchers could be used in the immediate term, given to people to buy their needed meds and supplies. And that would be going to the private sector, because that's what they're going to anyway. That's what there is. And so, but as a way of relieving the impoverishment, that's at least one aspect of the private sector that we spoke. So it wasn't just going to the private sector for money.
Okay, so sorry, there's two, it seems to me there are two really important complex points within there. So here you were talking specifically about understanding how people are accessing medication by engaging with pharmacies and potentially the broader pharma sector to understand where you might intervene with your cash transfers. Is that what you meant with that?
Yeah, yeah. If cash transfer is one possible vehicle, but I think the goal is enable people to get their meds and enable them to not have to pay for it themselves. Which
Okay. Okay.
Well, thank you very much, the group of financing. I think everything is addressed. I think following a bit on discussion we had yesterday, there's not much touched about how do we talk with the governments, engagement with the governments. So it's important because humanitarian crises are ongoing. So it's not one, and this will be, it's a chronic situation. I think we need to see how the governments take a normal, between brackets, a normal role they need to take regarding supporting people in need of medication for diabetes and not only, but also how the governments need to respond during the humanitarian crisis, activating different type of mechanisms. So I think I would see an engagement with the government before the private sector.
I think just to respond to that, the sort of emphasis that we had on data, right, is trying to sort of articulate what we would need to work better with governments, right? So the reality is that NCDs, diabetes are not being prioritized in stable settings, definitely not in humanitarian settings. So there needs to be a mix of, I think, proactive data management in stable conditions and then reactive data collection like we're seeing from some of the humanitarian organizations to make the case in sort of the request for financing that's funded through governments or outside of governments, depending on what the situation is. But agreed, I think we just leapt to beyond what we needed. What was next?
Can I just ask, we talking, the word emergencies came up, and again, in every group we have this issue of humanitarian emergency, what it means. Was that something that you were specifically looking at when you were looking at financing? Were you seeing a clear distinction between the financing issues in emergencies and in humanitarian emergencies and the broader NCD financing issues in low-income settings?
I mean, I don't think we distinguished. To be
No.
honest, it was a bit of a free-ranging conversation.
Okay.
So yeah, I think sort of articulating that we still need some basic definitions of like what are we doing at each stage of a crisis. So what is, I think, to this develop our clear action steps. What's the very, very bare minimum first 30 days must have, and then as the crisis moves forward, how do you layer services on top of that so that it's actionable? And ideally those steps are costed in some way and proven to be the most efficacious, but that requires some level of investment. Pilot investment came up a lot.
There's a hand at the back. I think we need the mics also for the online cartooning.
Am I quite quiet? Sorry. We also talked a little bit about the HRP process and the kind of data that might be needed in that, and also thinking about the different types of data, and that we might not need perfect data in order to kind of bid for a resource, but then when you're trying to deliver, you need a different set of data as well. So it's thinking about the different aspects of that.
So I put this data, that was your first point, data on is financing available and what financing is needed. I just wonder whether there's any action point, or if I missed, what actions are there within that around understanding? And in every group there is this issue of knowing, of the awareness of what is and isn't happening. And we heard earlier that we were told by Austin there's plenty of money around. So
Thank you very much. So this is more of a question, I guess, around perhaps the opportunity to feed some messages or work with WHO and the World Bank on these NCD financing dialogues that will be taking place in June, and then thinking about sort of the UN meeting in 2025 as well, just to ensure that sort of these particular contexts are also being considered. Because I do understand what we're saying about sort of NCDs being underfunded and under-recognized across the board, but I think using opportunities that are already there to be able to bring that message forward could be an idea.
Okay. Rachel and Kieran?
Okay, anybody in my group can, in our group can disagree, but my sense was that the first data point we made was the need for data on how many people are there, what are their needs, where are they, and that it's very hard to make the case to funders if you can't provide that basic data. So do we talk less actually about what data on funding do we need to collect? It's not that that is unimportant, but that wasn't so much a topic of conversation in our group. And then to Claudia's point, I think the point was made, actually it was by me, so I remember it, that maybe there's a message from us that might go to the financing meeting that's happening in a few weeks, or that could be built into the outcome documents for the 2025 meeting. Well, I just added that on, so it's a bit of a cheat, but anyway.
Okay, is there an action we need to do around gathering the data on needs? Is that something that this group can play a role in? We had another group that were working on monitoring and
I think we discussed the development of or WHO playing a role in the registry's development at a national scale, where the data is also, there is a clear interest of the people or the organizations and the health professionals within the country to contribute to that data in a proactive way, and also to develop a model where reactive data can be gathered in case of a humanitarian crisis. So that's the action we discussed. Also, can there be some financing to develop such a toolkit, maybe backed by WHO or another international body, so that it can be rolled out in a international, perspective.
Okay, so a
And the
proactive and a reactive
yeah.
element there.
And the other point, the action point, was the development of the framework, where we need to clearly define the steps that we need to, what are the steps that need to be carried out to respond to a humanitarian crisis, and costing each one of them out. And
What shall I write? If anyone has any advice for me in what to put up here, do tell me. I think, this is really complicated, and I think it's being recorded, and we've got the drawings, and we'll come back to it later. But so it's not to whip ourselves, but I think anywhere it's possible to think about something that in the next year members of this group could actually push for others to do or engage in directly, it would be really great to hear them. Yeah.
I want to follow up on that point. When talking about costing these different steps in the response, so I guess that gets done already case by case as the HRP gets developed. So if there's a need for diabetes care or NCD care, that's the job of the health cluster in the early stage to propose the interventions and to cost them. But in the group, were you talking about making that in a standardized, developing a standardized package for emergencies where those things are costed generically, that therefore this is a resource that gets used in emergencies to facilitate that process? Do you see what I mean? Because I'm just trying to say, within the group, this idea of costing the interventions, it does get done in at the moment, but maybe it's slow. Maybe they're having to do it anew each time.
So pre-prepared costed packages, is that?
Well, that's what I wanted to clarify with the group. Was that the feeling of the group?
Yeah, basically, it was thinking through how to kind of systematically have a way of approaching this. And so, yeah, it's exactly what you're saying. And just on the data bit, we did actually touch on the kind of need to have data before a crisis. So thinking about and also having a longer term set of services that might be delivered in FCVs, for instance, that you can then try and return to afterwards, and also having those with some estimates around them. But yeah, it's exactly what you're saying, Kieran.
Can I ask if you discussed anything on how, because you talk about demonstrating the needs. I'm wondering if whether needs is enough to motivate finance, whether there are other arguments, and certainly in the HIV and the Global Fund came out of activism at community level, highlighting a need which arguably was disproportionately responded to. And NCDs is disproportionately responded in the reverse sense. So it isn't just demonstrating the needs, it's somehow motivating a financial response to those needs, both at government level and internationally. And I'm just wondering whether that came up at all, or whether anyone has thoughts on that. Yeah.
I'm not sure that it's clear, but answer. But I think it's very important. Safe life, and people can be member of society and give benefit to society. And this is like resource, like a human resource, but for company, for another business, they need resource. They must save this resource for them, for example, who will be working in company or something like that. Without people, they cannot deserve something. They need people. They need people who work.
So they're kind of economic arguments.
Yeah, this is like arguments, and they if we save this life, they can give benefit to society, but it's not the society more, for example, exactly for business, company. I don't know.
So this is one form of needs, I guess. You know, there is a need for NCDs, and there is also a need for a society that maybe. I just wonder whether that was a theme that we need to bring out here.
Because this is very important. This is people who have chronic disease, have already educated, have already have some skills, and sometimes it's also we can save money for education, young people, for example. We can have already people who have education, and this is resource, which I say, human resource.
So how shall I write that? We're going to run out of time in a minute. I'm just going to put a kind of socioeconomic cost. Health economics and people. What's it? It's kind of quantify. Any last comments? We're going to move on in a moment.
Just one last comment on the WHO Best Buys framework for NCDs, whether that's also an opportunity to think about this same types of interventions. Sorry, which also incorporates some of those finance economics that Irina is mentioning. So that's already in place. I don't know, again, another opportunity to sort of think about how to build that in. That includes both a component of cost effectiveness, but also those are proven effective interventions with evidence base from many countries. So again, an opportunity for humanitarian settings probably.
Okay, so integrate plans. Yeah?
So it's still linked to that, and on the data point, I was wondering whether the question of modeling did come up when we talk about data, because we've been asked a lot recently in the context of Gaza, how long will people survive without insulin? Is there, in terms of data, yes, we can show the data on needs and numbers of patients, so do we need to be generating data on the consequences of not responding, and does that influence funders, or are funders just looking at need?
So we're going to have to move on. I mean, to me, that's a clear, critical point that underlies all of these questions. Regardless of whether it's relevant, if it's already there, we should collate. And I think that where there are elements of things that were needed, there remains a question of, are we able to pull together the available information, and have we done that? So to me, these themes are useful coming out. I'm going to have time for quick rapid fire, any things that have been missed. Yeah,
Sorry.
very quick.
Yeah, 10 seconds. 5 seconds, fine. Our action is to make sure that NCD is in all the flash appeal of the health clusters. Because we have, in Palestine, we have a $408 million flash appeal for this year, and NCD is part of it. So it's important that we push that NCD is and diabetes in the flash appeal for any health cluster of the emergency.
In the, sorry?
Flash appeal.
Flash appeal.
You know flash appeal?
I've heard of it. Okay. One thing I'm just feeling, I wonder whether I overestimate the importance of the community voice, whether it's a political voice or local level voice in creating the response from donors and from finance. I think that we don't have a group here who was specifically speaking to advocacy and activism, but I find it very hard to believe that NCDs are going to get the support they need purely based on a dry representation of the needs and the costs. It's going to take something more. And maybe it'll come out more in some of the other sessions, but I think that who is saying what to who and with what motivation in them, I think remains a big question around this. But we'll come back a bit later, and if any of these points come up again, I'll just quickly, so we had pooled philanthropies, advocacy synergies, skills and bridge building. I like this one in the NCD and the fundraising community. You know, there are so many ways in which these experiences have been developed outside the NCD community that need to be brought across. And I think this issue of fundraising and access to donors and the experiences elsewhere is going to be a really important piece of that. But let's move on to the second group, access to diagnostics and devices. I think it's going to be easier to come up with some clear action points there, I'm guessing.
Hello. So I'll try to summarize briefly. We started the session off by kind of defining the differences between in vitro diagnostics versus medical devices, because they're different things and they're regulated in different manners. And our objectives was really to kind of brainstorm or to co-create some solutions. And specifically, we were trying to think about a deliverable being 1 or 2 concept notes that we could pitch either internally within our organizations or out to outside funders. So those are our action steps. Okay. Yes. Our deliverable is 1 or 2 concept notes. Yep. So we started thinking about glucose testing and HbA1cs, and then the second half was about CGMs, or the second, third. And we started by highlighting what is currently known about glucose testing in humanitarian settings, which for the most part comes from the United study that Sylvia and others have done, which has showed that while capillary glucose testing is available in 70% of humanitarian camps surveyed, HbA1c testing and home glucose monitoring was only available to like 18 or 22% of camps. And so the question we had is, in an ideal world, where blood glucose testing and HbA1c testing is universally available to all settings, is there a specific implementation research study that we might be able to develop? And so a lot of things were discussed, and we kind of settled on this idea of focusing on either a longer-term camp-based setting, such as in a protracted crisis, and we would be looking at both point-of-care HbA1c testing, as well as the frequency of HbA1c testing among patients or people living with type 2 diabetes. And then in addition, for that smaller subset of patients with type 2 who are also using insulin, so in addition, offer self-monitoring of blood glucose. Okay, did I miss anything about?
Oh, sorry. Self-monitoring. Oh, yeah.
Self-monitoring.
I'll shut up.
Yep. Okay. The next topic we discussed was about CGMs in humanitarian settings, and 2 studies were highlighted. One, a very small study of 27 participants done by MSF in Lebanon, where they had patients under the age, or type 1 diabetes, age 17, under the age of 17, who had 3 months of follow-up where they were 2 weeks on CGM, 2 weeks off with a flash glucose CGM device. And they showed that there was a slight reduction in the mean number of low glucose events in that 3-month intervention period. And then Beatrice also highlighted the ongoing work from the Exceed study, which is looking at patients living with type 1 diabetes in Kenya and South Africa who are receiving care in the public health sector. And that study is looking at continuous versus intermittent CGMs versus standard of care. And their primary outcome there is HbA1c. And that study is ongoing. And so the question we then asked is, well, what about in humanitarian settings? What study or what studies or concept notes could we think about in that particular setting? And a lot of ideas were thrown out. One was about perhaps looking at a cross-border refugee population in Thailand, Myanmar, whether CGMs might be useful to help avoid hospitalizations in that setting. Another was about looking at feasibility, for example, in South Sudan, where maybe the environment or those conditions are quite precarious. And so the question might be just, are CGMs and sensors superior to lancets and strips? And then the third idea was perhaps looking at a setting like Cox's Bazar in Bangladesh, where we could perhaps look at 3 separate outcomes. The intervention would be CGMs plus education, and the outcomes could potentially be first, feasibility, usability, acceptability. Second, a proxy such as HbA1c. And then third, perhaps also to look at validation, because there are concerns that some of the point of care, that some of the devices may not be as precise or as accurate as others. And then there was a recommendation to do a couple of things before engaging on any of these studies. First is to host multi-stakeholder workshops where we can get insights from all of the players locally, as well as to have one operational partner who is actually operating in country but outside of the refugee camp, so that when the findings are available, the governments locally can't just say, oh, that's just something you do in the refugee camps, you go ahead and do it, but that there's some accountability perhaps to the local population as well. Is there anything I missed? Go ahead.
Thanks, no, great summary. I think critical also is sort of is the pathway to implementation, right, that we want to look at with the sort of implementation research questions to really generate that evidence now on service delivery solutions for appropriate glucose testing. So yeah, I think otherwise is greatly summarized. I would love to ask our virtual cartoonist to replace that insulin vial with maybe a blood glucose meter. Maybe you want to look online what that looks like. And we are so often, thank you, we're so often overshadowed by the access to insulin when we talk about diagnostics, so that's great, thank you.
Okay, thanks. So we've gone to an opposite extreme of some really detailed responses around very specific and clearly actionable. So if I understand right, we have basically you've demonstrated the need and you've identified gaps in evidence that you believe could be filled usefully as actions within this group to improve the willingness and the availability of glucose monitoring. And you had these 2 key ones you'd mentioned. One was a demonstration project in a camp setting looking at HbA1c and self-home glucose, if I understood right. And the second was showing the added value of CGM in a variety of settings compared to the status quo, with a multi-stakeholder and an implementation research strategy embedded within it, which makes a lot of sense. Any immediate thoughts and comments? Yeah, or other elements, other issues that we would perhaps put as additional action points. Philippa and then Helen, or Helen and then who is Helen has the.
I just want to go back to the HbA1c question, and we were talked a lot. Well, for me, I'm going to talk about it in the context of type 2 diabetes, and there is, we said I think Beatrice was saying it's not listed in the PEN diagnostics tool package, but it's listed in the Pen Plus diagnostics tool package. So again, I don't know in terms of what WHO is saying on it, but like for the hypertension guideline, where there's now a clear recommendation around the frequency of when people need to be seen clinically, there is not, as far as I'm aware, that recommendation around the frequency of when to do an HbA1c or how often to do it. Is it 6 months? Is it an annual one okay? I mean, many people in the UK are getting it annually for type 2. So that's a cost, it's got a cost attached to it. And, we hear stories of it being done every 3 months, every time they come to the clinic, which is a real, not good use of resources. So that kind of clear, graded recommendation, if I want to say it, do we need that to be for ministries to be clear? It's okay, and then of course we've got to act on it. It's no point having that result if we've got clinicians who are not got clear algorithmic guidelines to step up treatment when needed.
So it's a kind of boom and bust, isn't it? You've either got no HbA1c or you've got it being done every month. So I'm hearing something around some kind of campaign package around HbA1c that needs to be clearly designed. Is that an action point? I'll put it there anyway. Yeah, go ahead, Philippa.
Well, I think Helen's partly answered my question. I just wanted to understand more about what this demonstration project is intended to investigate. What is the question that they're wanting to look at? So I'm understanding some of it's around the frequency of HbA1c use. Then I wanted to understand also about the self-monitoring of blood glucose. Again, what is the question that's to be answered? I mean, I think one of the basic challenges that we see in the very low resource, like the South Sudan setting that was mentioned, is really, people living with diabetes who are illiterate, innumerate, and teams really not understanding how they're going to be implementing the blood glucose monitoring and what is going to be the value of it to them or to patients in that kind of a setting. So that there's a whole lot of questions around that we see, but I don't know if there are other things that were envisioned in terms of what you're trying to understand about self-monitoring in the camp.
So I think your phrasing is from the clinical perspective, which is sort of also, Helen, what you were referring to on the HbA1c frequency, which is an addition, a question of that requires looking at. I think what we discussed more is, so the question we're trying to answer with implementation research is people should have access to regular glucose testing, so HbA1c in a facility, right, or with BGMs, or in a laboratory, and as well as self-monitoring. So how can this be achieved in a humanitarian context, right? And what does it require? And of course, it requires guidelines, and training and education, but also that, from the community and either the humanitarian actors who run the camp or the government that within the country that the refugee setting is. So I think it's more sort of really on that implementation. So the key is the implementation research. If we come up with a co-created implementation model, like through a co-creation process, for example, in a specific setting, and then test it out, and then evaluate that process. And of course, some of the clinical questions, are key to answer at the same time in a way, or review, in a way, to have answers to some of the feasibility questions that may come up.
A quick comment on that, just because MSF Paris is about to work on a project with Santa Debet's a bit involved in as well, looking at South Sudan and Central African Republic, these very challenging settings where at the moment patients are coming to the clinic to get their insulin, so doing the home insulin management, but also implementing self-management of blood glucose, which is not being done. So they will be doing that.
Yeah, so as we have also MSF Access campaign around, so I think we have to be very concretely of an analysis, a study, and a complete document provided by Access campaign on diagnostics devices and diabetes. So I think the JAMA report can be a bigger one, and I think we give a task to Access campaign for that. So they have a checklist for 2024.
Okay, and that hasn't been done yet? Okay. There was a hand at the back, yeah?
To Philippa's point about, patients that can't read, they're not educated or they're not literate. We have a few cases like this where, the caregivers of young children with type 1 diabetes, a grandmother, mother, can't understand the numbers on the glucometer, and they've been copying it out on a notebook. Different ways to sort of deal with this. We've been using WhatsApp groups, and which is also useless because they can't type. So we've been communicating with them via voice notes on WhatsApp. And so I think the actionable or the output that could really work for all of these four is investing in and supporting communities, because communities are really the bridge between the HCPs and the patient in these ways. So yeah, that was my point. Thank you.
Is there an action point I can put with that?
Yes, supporting and investing in communities, peer support communities and groups.
Okay.
Yes, like context appropriate and culturally.
Okay. Any last comments on this issue? I'm also just wondering about, again, the financing of this. Did that come up at all in your group? Is there a need to demonstrate the added value in terms of the best buys and the cost efficacy of these in achieving outcomes?
No, in fact, that was another point I completely forgot about, because I didn't see that come up, and Beatrice and I were discussing it earlier. I think for CGMs, I mean, we absolutely need to be demonstrating and trying them, but there's a huge issue around the finance and the costing of them. And my understanding is that it's been really difficult to engage manufacturers in discussions around the cost and in reducing the cost. So there's a lot of work to be done there. There's also the TPP that was done by FIND. So seeing if there are, companies that are interested to invest in developing something. But I let Beatrice compliment.
And is that just for CGMs or other diagnostics and devices as well?
So your comment was to the CGMs. We discussed in general that if we were to do some implementation work, it has to have an economic analysis also. What does it cost? Because obviously, there'd be an increase in resource needs, and then tie that to, outcomes, better quality of life, and better care provision. So yeah, so it wasn't a detailed discussion, but it was definitely acknowledged important data points to capture during any implementation work, and then leverage it accordingly.
Great. Okay, any last thoughts on this group? Oh, two. Yeah, one at the back.
I was wondering if the group had talked about the role for community health workers in addition to peer support, because in some programs we have community health workers doing household level checks for blood glucose, for example.
Can I just add?
Yeah, I'm not trying to pass the buck here, Claudia, but at the very end, unfortunately, we only just started speaking about access to blood glucose testing. And while we're dreaming about CGM for the future, we cannot forget about the cost prohibitiveness of access to SMBG now. So, Claudia, can I turn to you to recap kind of what you said? And I think it's particularly helpful, with your background and what you do.
I'll try to reproduce, but it was just basically about being cautious about the framing of some of these discussions around CGMs, which obviously choice is incredibly important for everyone, and everyone should have access, obviously, to the breadth of products. But also thinking about, I would say, sort of too much of a focus on CGMs might give the perceptions that some of the test strip manufacturers might be sort of, I'll say, off the hook for really addressing the affordability challenges that we see with test strips. And I don't have an actionable point for this. So if anyone wants to come in. Yeah, exactly. It's just about being mindful, exactly. About
I guess. Yeah. So the implicit question here is, are we risking unintended negative consequences by highlighting CGM. And I think that applies across the board. When we talk about GLP-1s, etc., are we, is it okay to reach for the stars and also keep focus on the minimum standards? And I think that, as you say, being mindful. Okay, 2 quick comments at the back.
One quick comment, keep being mindful of what has just been said about SMBG. Also, perhaps making the case for getting CGMs on the essential medicine list. We see prices in my country, in India, going up for CGMs without any improvement in products, and there's seemingly no cap on prices of CGMs. So, yeah.
And Helen.
And Beatrice and Fine did that work around the price of the test strips, and I think I was getting it wrong. Is it 0.5 or 0.7, Beatrice? Sorry, but 0.5 per strip. But again, we talk about for WHO having that tool where we see transparently what countries are paying for insulins. Are strips in that? Are they aiming to do that for the diagnostics as well? I mean, in terms of transparency, do we know what countries are paying for their strips from your work? But
I think we're going to run out of time, so let's. But
yeah,
that's going to be part
but
of the
just
campaign dossier.
Just in terms of transparency of pricing of medicines, is there transparency of pricing of the strips?
And last comment, Nomathemba.
One thing our group forgot was that access to diagnostics and devices should be paired with peer support.
Should be?
Paired with peer support.
Paired with peer support.
Yeah, or peer support groups.
Okay.
Yeah.
Okay, so I'll put that here, plus link to device access. So there's an explicit link, access and delivery. Okay. Thank you very much. And we'll move on to the third group.
Great, I'm here already. So, okay, thanks. Hi, everyone. So, our group was talking about this concept of a minimum initial service package or toolkit for diabetes. So it's something we've been talking about in IATA for a number of years. Is this something we should be thinking about, creating? Is this going to be useful? And at the WHO NCDs and emergencies meeting in Copenhagen, there was also quite a strong call, and I think we've also heard it yesterday, this call for a service package. And so just by way of background, for those who may not know, there are a couple of existing minimum initial service packages. So there's one that exists for SRH that's been around for a number of years, and there's a more recent one for mental health that's currently being piloted and studied. And I think for the one for SRH, I think the general perception, and we also spoke to people working on it, is that in fact, although it's supposed to be in a minimum initial service package, in reality it ends up being the package that's implemented for a couple of years. There's kind of a sixth objective of the package, which is supposed to be integration of SRH into general primary health care, and in reality that's the objective on which people get stuck, and it sort of stays at that initial package. So I think in the group there was general agreement that there's recognition of the potential importance of having a minimum service package, but not really this concept of an initial package, in the sense that we also acknowledge the reality that it often does anyway take time to get that first package onto the ground, the first medications onto the ground. And so it would make more sense to look at an essential service package, but then we would identify within that what are the most urgent priorities to get to the field. And in reality, this would be focused on insulin and on glucose meters and strips. There was a little, just as a side point, there was quite an interesting discussion around the insulin, because in the H3 package, which I'll come to later, that was not put at primary health care level. Many of us are using insulin at primary health care level, and of course in an emergency, people with type 1 diabetes need access to insulin no matter what level of care is there. And so some discussion around whether actually that insulin provision could just be available in general regardless of the level of care, and some discussion around this concept of a hotline such as was used in Ukraine, where people were able to phone up and understand where insulin was available. So just making sure that insulin is available in general, separate from the level of care. And then some discussion but no real decision about how these a package would be formulated. Would it be by level of care or would it be by objectives, as was done for the reproductive health kit? We didn't have too much discussion around the components of a service package, but you know, I mean, obviously the inclusion of essential medicines and diagnostics, including the capacity for multi-month dispensing for medication, the inclusion of clinical treatment algorithms, and again, really simplified algorithms that are easy to implement in an emergency, the need for service delivery, SOPs, the need for identification of monitoring and data systems and tools, the need for training of healthcare providers, and there was quite a bit of discussion around the importance of kind of the community level of care and identifying, you know, what levels of care would happen at the community, including, again, peer support, which is coming up recurrently, and including perhaps concepts of stable patients, you know, being able to be managed at community level with drug refill happening at that level. And then we talked a little bit about what is already existing. So there are many things that are already existing. We didn't have time to go into detail of those, but I guess the one question we touched on is, you know, could one of these be the basis of a service package? So there is this H3 package which exists, which theoretically could be interesting, but in fact, we understand that it's at quite a basic level, and it really doesn't even equate to kind of the essentials that would be needed. So it would be interesting to look at and learn from, but perhaps it's not quite the starting point, whereas the NCD emergency kit, for example, could potentially be a starting point already with the key drugs that are needed. One of the things about the NCD emergency kit is that that's designed for primary healthcare level, and so, of course, potentially a service package, you know, would need things for secondary healthcare level. The interagency health kit exists and does have drugs for secondary healthcare level, but we would need to understand whether that was sufficient or not. And then there are various other guidelines. There are operational guidelines. There's the IFRC community package. So again, the idea of community, could this be something incorporated into the kit? And, you know, there are tools IATA has worked on, like the switching guidelines and the thermostability document that's being done, but in general, the conclusion that there needs to be a proper scoping and understanding of these guidelines. Then we understand that WHO is planning to do a scoping review for an NCD minimum service package that Kiran will be undertaking. So that's going to be outlining the contents of a package, and that will be a 6-month scoping process. And then, of course, the question, will WHO then develop this? Then they would need to source funding and decide whether to develop it. So what we had a bit of a discussion on is, what is the IATA role? So certainly to be involved and contribute to that scoping. But in the group, we saw that, you know, we know that the WHO process would take time, so that there could potentially be some added value in IATA looking into something on a shorter term basis. We'd need to probably have a consultant for that, but, you know, firstly doing a bit of a scoping of what exists, what would need to be modified or adjusted or made more accessible of what exists, or what would need to be developed new. And then the thought that IATA or IATA members could have a role in piloting a package and getting feedback on that could potentially inform the WHO process. And just one last point, that we for this process, it would be really really important to identify partners and identify those early and engage with them early. What else? That's it from Kieran.
I don't know if this counts because this came up while we were walking.
Oh, then I missed it.
Down to the room afterwards.
Yeah.
But actually, it was another part of IATA contribution is where members of IATA are working in organisations that are carrying out pilot activities, particularly around the community service delivery side, evaluating these and, you know, producing some data would really feed very valuably into this process, because if a minimum service package contains guidance on what can be delivered at community level, there is still a research gap there. So if we can show that which aspects of service delivery can be carried out safely at community level for which subsets of patients, this could very usefully feed into the development of a kit. And I think we're looking at the IFRC work particularly on that, on the community service package, which I don't know much about. But yeah.
Sylvia, anything extra? Or anyone else from the group?
I just wonder whether we have in the room any volunteers. So you mentioned IFRC. So there's a lot here where we're talking about IADA playing a role, either as a collective, a convener, an engager, a linker of people, which I think is implicit for all of these. But sometimes there are points that refer to somebody here and their organization taking a responsibility. The campaign have volunteered already to produce a dossier on the diagnostics gaps and state of play. I just wonder, with any of these, we've had some research proposals in the last group, and here quite a specific and very complex area to fill, a gap on the feasibility, acceptability, and impact of community packages of care. Yeah.
Thanks, Tom. Yeah, so lots of research on packages of care for NCDs exist in low resource settings. So that's already out there. So I suppose it's then maybe if those exist somewhere, what happens when a crisis occurs? Can they be repurposed? Can they continue? And there's also evidence that where CHW networks exist, they have managed to continue care, not necessarily for NCDs, but for other conditions in crises. So yeah, so then we did this. It's based on interviews with different humanitarian organizations about, for NCD care in crises, how did you manage to maintain care? And we did a survey and had 98 responses from different organizations with some geographical gaps, but a pretty good response rate. And the community health worker role was really important. And there were places where it didn't exist already within programming, and organizations repurposed other networks from other organizations or who were doing other things to help to continue NCD care. So it definitely seems to be a really resource that we should be building on in general in crises.
So you're arguing there's perhaps less of a research gap than Kieran is suggesting, and then the action is to collate the information and present it to Apostolos' grandmother so she can go out and insist on it. Helen.
Kieran, just a point of clarification. So the document that you're going to work on for the next 6 months or whatever it is. So is it just for diabetes? Is WHO tasked you to do that just for diabetes, or is it also cardiovascular disease, hypertension? We can't talk about diabetes without talking about hypertension. I just wonder the scope of that toolkit, because obviously we need a minimum initial package for people living with hypertension, heart failure, etc. Just wonder what the scope of that is. Is it purely diabetes?
No, it's NCDs and it's multi-level, so community, primary and secondary, and it's probably not 6 months. It's probably two months, but that's just for the scoping. But as I said, that doesn't guarantee that there's a decision to actually work on it by WHO.
Kieran, you probably know this very well, and obviously others do, but just the existing packages that are out there have also been costed. And so, Stenberg et al. And Watkins et al., those are, I think, the ones you're probably referring to for NCDs. So there's a lot of work already to build on, which is why you probably said 2 months, right? Instead of 6.
Again, I'm aware that we are sometimes talking about initial response to an emergency and sometimes thinking about general stable settings. And we need to take all of these points and see how do they relate to those different environments. And I think sometimes I sometimes struggle because I realize that I'm thinking of one entirely different construct around a problematic from someone else mostly relating to this first 30 days acute conflict or humanitarian emergency and setting with no access to anything. And it's a very difficult thing to pull together. I think one of the things that's coming more and more clear to me is how we're going to need to be able to distinguish and remain relevant and valuable in all of those spaces, unless there is a space we don't need to be in. But what I'm hearing here is we do need to be in all of those spaces. Okay, any last comments on this one, Apostolos?
Yeah, just to add two little things to support your point. So already WHO does there's a tool package who is looking at the health services for migrant refugees in different countries, an assessment that's taking place. Secondly, there is already a research agenda for migrant and refugee health. So I think those elements as are involved in different countries' assessment and research part can be included in this wider general picture. So I think there are dots that we can still connect and bring to the point. Over.
Okay. And just one issue again, since because your point the other day about your grandmother and about the importance of translating knowledge into a way that it can be used by community is something that I see behind all of this, that if it's important to have people, and why wouldn't it be? Why wouldn't it be important for the child of somebody who is unable to access their medications or the person unable to, for them to understand what is blocking access, what is forcing them to pay? And I think one of those areas, generically in all of this, you know, I don't know if these things exist everywhere. In Cape Town, there's a great unit called the Knowledge Translation Unit, which is there, and it worked hugely during COVID to take the science and understanding and turn it into a package that could be used by communities to drive response, to monitor response. It strikes me as one of the big areas that we could add value from this group. Okay, any last thoughts, or we'll move to the final group? Okay, final group. Rapid information sharing.
Hi, so you've got two for the price of one. So I think Anna had a slide to share. Oh, there we go. All right, we've got it here as well. So our discussion was about the key data points and data sources that could inform the immediate response to diabetes needs in the first 30 days of an acute crisis. And so to anchor that discussion, we had Liz Jarman present her ongoing work talking to various organizations to understand what data that they're collecting in the face of an acute crisis, as well as understand the data collection processes, where are those data coming from. And then Kiran Mohan shared a bit about his work looking at the data that's currently being collected as part of routine care delivery in more protracted crises. And the main theme that came out of this conversation was that when we were thinking about, does there need to be a new tool that's developed? Does it have to be diabetes specific? And there was a kind of resounding answer that probably not, that was not a good idea, and nor would it be feasible. That instead, there's actually multiple points at which existing systems could be leveraged to integrate diabetes. And specifically, we drilled down into what that means action item wise for us. And although we did not get into specifics at this point around timeline of each of these, but we talked a lot about advocating for the inclusion of insulin-dependent diabetes in preparedness plans. So things mentioned were, of course, absolute number of persons living with insulin-dependent diabetes. There was some discussion around talking and advocating for inclusion in registries of different countries, and also being involved in helping to code how that data is stored, because currently there's Laura Miller mentioned that often things are stored as NCD and not much more detail, and it might be a good idea in certain contexts to use ICD-10 codes, for instance. And then we also talked a lot about the importance of including in preparedness plans information about the location of country offices of WHO, the UN, as well as mapping various other non-governmental and volunteer organizations to just understand who's around to help and where they are. There was also mention of mapping where medicines are, as well as existing supply chains and distribution routes as part of country preparedness. In addition to that, we talked a lot about other ways in which, getting information about just absolute numbers of people living with diabetes. And one of them was the UNHCR vulnerability criteria. So when someone is registered as a refugee, they also have their type 1 diabetes recorded. And then there was mention that in order to really influence change on a broader level, integrating, or I suppose adding diabetes into the WHO list, Global Health Cluster Multi-Sectoral Needs Assessment. We talked about how there's different tabs, and having insulin-dependent diabetes be one of those tabs, so to speak. And hopefully by doing that, that would actually influence a lot of the organization-specific acute crisis assessment checklists and emergency kits, so that those include, addressing type 1 diabetes specifically. And a great point was mentioned that organizations could be doing better advertising to donors, to have them support emergency kits or send money, and to do a better job discouraging sending concrete supplies due to a lot of mentioned waste and or incompatibility with what people need or use on the ground. So that was the first piece. Anything to add there, Yvine?
Well, again, sort of corridor discussions on the way out. So a lot of the people who gave us responses are from large operating organizations, implementers, and so then have their own internal tools that they use and that they might be used to deploying really quickly, and they have emergency teams, and they might even use kits. So for them, they already have their own internal things, and maybe integrating better type 1 diabetes into those is a solution, and that some of those tools are influenced by cluster tools. And so if we then work at the cluster level, we'll influence many of the bigger organizations. But on the other hand, a clear message, I think, is obviously contexts are very, very different. So while we can support, preparedness plans, and like Kieran, for example, has produced an operational guide, which is not yet published, and other regional WHO offices are looking to prepare operational guidance on how to do preparedness, response, and resilience for NCDs. So that kind of stuff is underway. So an action point is that IATA can potentially contribute to and influence what goes into those operational plans. That's one thing. But we were discussing already there are some contexts where a government might be functional and that they are the obvious, I suppose, contact point who can do a lot of the coordination. But there are other contexts where there isn't a functioning government, and there are contexts where there's no cluster mechanism, and maybe where there aren't that many large international NGOs, but there are lots of small NGOs. So I don't think we came to the group in the room felt that an additional tool was not the way to go. But at the same time, there is this need in certain contexts where the government can't lead, and where maybe there aren't that many international NGOs and the cluster isn't there, or it's not there yet. And I think Kieran, Job, and Pooja will have things to say, so we'll give you a moment to do that in a moment. But yeah, so I think action points about this were that we need to talk to Linda, who was on one of the panels yesterday, and I think some of the other action points we can go to after the next section.
Perfect.
Yeah.
Yes.
Talk to Linda.
Yeah. Action point 1. The other main theme that came out of our session was the importance of context in driving where we get this data that we're seeking, and that, of course, there's a huge variability across countries when it comes to the existing health information systems. And when we think about getting that data, that who's around to help, where are the existing supplies, and what is needed, especially when it comes to type of insulin, there could be some data sources that we're currently not leveraging that could address the limitations of health information systems. And one of them was something that was mentioned yesterday as well, which was that sort of mobile data health chart that travels with the patient. And Laura Miller raised a good point that perhaps, this could be something that involved in a phone app, but it could also be a physical book that's just standardized. And IATA could play a role in that, in helping develop that to account for the mobility of people in these settings. And then another idea that came out of our session was leveraging volunteers in areas who are already collecting data about the community. So Lars mentioned, community feedback systems. They could be used as part of response, but also just in the context of preparedness, especially where there's not a robust existing health information system in the country. Other ideas that were brought up for data sources were leveraging pharmacists, which I think was just mentioned earlier, as well as possibly big data, mining things like Google searches for insulin or doing some work in that area. Then also, of course, earlier today we heard from our research sessions about exciting new modeling being used to map prevalence of type 1 diabetes or mapping insulin availability at the household level. And so perhaps those could also be leveraged in a broader way.
So I think just a lot of what we talked about, or part of what we talked about, really echoes what others were talking about as well in terms of community networks. And so Lars brought up, as Angelica said, the Red Cross, Red Crescent movement have these community networks, and they're already involved in kind of community data mining and providing care and so on. So the Red Cross, Red Crescent movement already, well, mainly in Kenya, it seems, already utilizes those existing networks, and they're very localized. So it may be a resource to build on. And at the moment, they also don't have NCDs in their tools, except for Kenya, I believe. So that's a kind of practical, avenue to pursue in a way, to go through the IFRC and see if their local networks can make sure they focus on NCDs. And also then the idea of peer support groups and groups, so community health providers, but also the peer groups where people are already in communication with each other, that those are a potential to be mined in the time of a crisis. And so what probably needs to be done is that in advance we try to map some of these groups and networks in each setting, and that there are, we know there are things underway. Irina told us about the IDF mapping. We know that, for example, ISPAD has a strong network of clinicians in many countries, and so maybe a role of IADA could be in looking at preemptively mapping some of the needs, so that we do some proactive as well as reactive mapping, as Sana had said. Anything else? Yeah, I think that's it. Anyone from the group want to just add anything we missed before we turn it over to the rest of the group? Oh, yeah. Thanks.
Okay, come on. Any thoughts? We're closing soon. Yeah.
Yeah. Sorry, just very quickly. A lot of talk about mapping, and I guess you know about the international humanitarian mapping. This idea about where you could kind of get everybody something that's interactive. Yeah. So you could everybody would know to get on this map. It doesn't have to be run by Google. It could be, but somewhere that everybody knows where they can go. And you would have what supplies are where, if they're running out, you could have, where the nearest pharmacy is. But, obviously you'd have to prep that a bit and alert people to that. But there are tools out there that could be interactive and not dependent on big tech. That could be very useful, I would have thought.
That makes a lot of sense. Thank you. I mean, I'm aware of those mapping, but hadn't actually put two and two together. That's something that we could utilize for this. Thank you.
Any other? Yeah.
I just want to reinforce, Tom, in the fourth group, Tom, the comment you said right at the end of the session. I just want to reinforce what you said, because you said that actually in rapid responses in the information you can gather, sometimes that's far greater than the information that the country was routinely gathering. So I think any efforts made to develop rapid information sharing in humanitarian crises, let's take the opportunity to also be pushing for routine collection of information that's really needed and would be very helpful to have.
Thanks. I had two questions about I guess the bit about the new tool not being needed. So a new tool is not needed. The title is information sharing process. So is that to say that a tool isn't needed, but maybe a process is, or that neither a tool nor a process is needed? So that's just a question, if you could clarify. And then this, I guess the main part of the question is thinking back to, I guess, the origins of us thinking about this, which was probably Ukraine, and the observation that getting data on needs, on where people were, because even where there were registries or information prior to the war, people had moved, was very, very challenging. Data on where the supplies were, where stocks could be mobilized, given that a lot of supplies had been lost, and then just the logistics, the warehousing to be able to transport that. I remember people like Irina, and I remember Sylvia, but also I saw Slim on the phone for days and days and days trying to get this information to be able to support teams to respond. So I guess having seen all that and seen how long it took to get this information, was the conclusion of the group that Ukraine was an outlier, a sudden onset disaster that no one except maybe Novo had predicted because they had a huge stock, ready to mobilize. But was it an outlier, and that having a process won't normally be needed, or because I think in Ukraine that would have made a difference if we'd had this in place beforehand. So maybe just some comments for clarification there.
So I do think that the voices in the room seem to suggest that organizations tend to have their system of doing things and their checklists. And I think that being said, that isn't mutually exclusive of the idea that perhaps synthesizing what organizations are doing and coming up with some sort of guidance or checklist for different settings, it doesn't mean that wouldn't be useful. But I do think the conversation did, revolve more around the fact that, organizations felt like I would say, to answer your question quite directly, it felt like in the context of our conversation, the Ukraine was more of an outlier.
Well, I mean, Irina, you could answer this as well, but definitely from what you contributed to the conversation was that in Ukraine, the information that was needed was all about delivery and supply, but that you felt that the Ministry of Health should be the people who manage that, and that, I think that a lot of our conversation came back to preparedness. Mm-hmm. So that if we're encouraging governments where they are functioning to do the preparedness, it won't be so difficult the next time. I think that was kind of the key message that came from the room, but obviously then we acknowledge that that's not possible in other contexts.
And also that could be facilitated by what Kieran's talking about, which is having perhaps a more transparently standardized process that's out there that people can look to if they are in a situation where they don't have that preparedness, or to help support that.
Share some negative example, because for beginning it was how chaotic. We afraid that we have not insulin, and the ministry very quickly react and make this like Google form where what you need. Of course, they got a lot. I see this and I saw this information. Different people, Ukraine, big country. And it is finally, it's not possible collected this information. Then what we recognize that it's not possible deliver. Of course, in Kiev it's possible, but in big city. But sometimes like bombing in Chernihiv and nobody can go. And I remember this one, my student go deliver because he go to parents, for example, like this. But it's individual case. And then we collected from my side. I have a group which I told about before. that they connected with some doctor who main in some region. Not everybody was affordable, but anyway. And also another case, Ministry of Health has also channel. And then we collected, but from our side it was more like from floor. And they listen at beginning of war, many people displaced to West Ukraine and stay, not go to abroad, stay in this place because it was more safe. And Ministry of Health sent more insulin and supplies to this region. It's like it was immediately. And also some of the people was lucky in Kherson because maybe they, I don't know, but they sent to Kherson, which was after a few days was occupied, more supplies for this territory. But anyway, it's not necessary do what you cannot. For example, like we get this information and also patient wait, maybe help, but it's not possible. Really, it's not possible. But to be honest, I told in our groups that the data, of course, it's important. Anyway, we have some data, and we have different data now. But more important, action. Doesn't matter 5 people or 10 people, but give to them supply for now. They can share for beginning, and then you can deliver more, and you will know data. But very important, quickly action.
Any last? Oh.
Just reflecting on what the people in the room were saying, I think we need, instead of saying it's a terrible idea and it's not going to work at all, we probably need to rethink about who it's targeting, because we're not targeting MSF, we're not targeting IRC and DRC, because they have their systems, they know, they have their networks already. So you're thinking about organizations which don't have such robust networks that we can assist. So maybe instead of it being a sort of tool that we thought everyone would use, maybe this is a tool for community groups, maybe this is a tool to support those small networks and get them the information they need, and vice versa, is one thought. The other thing is, when we talk about integrating into the cluster system, that's great. I completely agree that we should have insulin as part of the cluster system, but the cluster system is not there from day one, and there aren't that many clusters active at any one time. So Turkey or Libya or places don't always get a cluster. And if you don't get a cluster, who is pushing this insulin? Who's going to be pushing that in Libya? Who's pushing it in Chad? It has to be people advocating from the ground, and we need to work out a way as IATA to support that. And maybe it's not by focusing on IRC and DRC and MSF, but it's instead thinking about how we can help others through this. Also, very different crises, very different contexts, but in Turkey, we had loads of data and it was really easy, and the Ministry of Health didn't need any help. So it's not about every crisis you jump in and be able to help, but maybe some of them we would be able to help with. Also thinking about IDF and their diabetes atlas. Again, who's that targeted at? It's not the big organizations, it's small organizations. So maybe we need to shift our viewpoint of how we can assist.
Although, don't overestimate the data capacity of MSF. I think there is.
Don't worry.
But I think it's a really important question that we would need to dive in deeper. Is there a role for IATA in supporting a improved, maybe not, one size fits all, but a real focus? Because even after more than 20 years, and we don't have one for HIV, and the need is clear. There are multiple different things, but there isn't really a ready-to-use kit, either for estimating the needs, the emergency preparedness side. Even at WHO, it's really poorly designed, and that's coming from WHO, or for monitoring. So I think it's a powerful thing for us to take away. There was somebody's hand up here, I thought. Last thing, or we'll wrap up. Okay, great. Well, we got some action points. I think we got a lot of action points, so a little applause. This thing's quite dangerous. That's why you put the thing over there. Just a few little. I think it's difficult to come up with action points on some of these things, because for me there are still a lot of elephants in the room around what exactly is the role of IADA in this? What is your space here? And I think from the earlier session, that point about the importance of this as a network for developing partnerships, and atypical partnerships, beyond clinicians, to patients and communities, to human rights lawyers, to economists, and for that group to be a convener of others around some of these things and in identifying gaps. And it strikes me that unlike HIV, where the whole apparatus of the global HIV response was built around needs of low-income and middle-income settings, that's where the prevalence was, that's where these things started, and UNAIDS and WHO and all the rest. For diabetes, it's not like that. And I just wonder whether we, perhaps, and I'm really an outsider in this, whether we underestimate the importance of IADA or groups like it. And I need to see where the Federation fits into this and where other groups. But who is really focusing on not humanitarian emergencies, but humanitarian settings? And that means settings where access to NCD and diabetes care is not assured. And mostly what we're doing is looking at settings where it was to a greater or lesser degree available, and then it disappeared. And that's where emergencies fits in. But I think we need to somehow untangle that discussion if we're going to be able to break down. And there are other issues around the distinctions between T1, T2, NCDs writ large, and then global health, and whether we are able to maintain, whether we need to maintain a space, or whether we fit into the broader health agenda. But I do think that the discussions we've had shows that there is a real need for actions from IADA and from this group. And I think it's a really powerful set of ideas and thoughts have come up. I look forward to seeing where we go next with all of this. But I'll pass over to Sylvia. Thanks, everyone.
I'm just going to stand over here. Thank you so much, Tom. I always find that that's the hardest part of the symposium, is chairing this last session, bringing these ideas together. And thank you, Emma, online for your art. We look forward to looking at it in detail more later. It's not easy keeping up. So yeah, we've come to the end of the meeting. Thank you all for coming. I know everyone here is extremely busy with their lives and all these things going on, and everyone coming in virtually and in person. It means a lot. And I've certainly learned a lot over these last 2 days. You always have to let the information settle in, sink in, synthesize it all. We as IADA and team leads, we're gonna, write this up, and with this new phase of IADA, we're really excited to hone in more and develop exactly what is our place in this world, if you will, to Tom's point. How can we be most helpful, and engage all of you more concretely and more actively and more regularly than we have been able to in the past. So we're really excited to do that. We would love to hear your thoughts, your feedback, genuinely how you think we can help. Maybe it's something we haven't even thought of. So please do reach out totally informally. You can email us or, on any of our upcoming roundtables or meetings. But we do really welcome feedback, because ultimately, I see our group as a kind of a family. We all need each other, as different as we all may be, to make this work. And, I had never thought of including human rights lawyers in this. I mean, it's kind of obvious now, but here we are, so Lena, we love you. We hope you'll stay and help us out. So in any case, I just to say that I've learned a lot, and I'm excited to see kind of how we move forward. So a big thank you also to all of the speakers, for all of the moderators, to all of you who submitted posters and research and presented your work. Really enjoyed all of the sessions. Thanks to the IADA team for all of your I get emotional just thinking of it, because just working with such a great group of volunteers for so many years and having this opportunity to kind of grow together, it's special. It really is special. So thank you to Helmsley, to Gina, and to James for your support, believing in us in a way, giving us this chance, this opportunity to kind of move to this new stage. It's really special knowing that we're very aware funding is limited right now in this global environment, and so we're very grateful to you. Thank you to the Sarin team for helping us pull this off. Thank you so much for all of your hard work. To the AV team for making the AV work smoothly. It's important, thank you. To the hotel staff here at the Royal Olympic for your hospitality, to MSF Greece for helping us, coordinate a lot of this and some of the speakers, and for the work that you're doing here, to Intersos as well. It's very important work, and we can learn a lot from you here. Especially also a thank you to all of you with diabetes, with the lived experience that have come, with your vulnerability and openness and your patience with those of us that don't have diabetes as we're learning the ropes and how we can best help. We are glad to have you here, and we want to hear your voices. So please reach out anytime. We hope to do a better job of that in the future. Thank you also to all of the humanitarians in the field that are doing the heavy lifting and all of the hard work. I am very aware that I am a physician living in Boston. I am not in Gaza. I am not in Sudan doing this work. And really, those people deserve all the credit, and we wish they could be here. We've had visa issues with some of them coming. It's not easy. But there, too, we hope to engage more people that are really actively in the field in the future. But thank you especially to UNRWA, to Saita, and to Shata. Honestly, you're heroes to me, all the work you're doing, especially in the diabetes sphere, reaching out by WhatsApp and, just really actively wanting to help. It's visible and it's special, and thank you. And our hearts are with you. So thank you for coming. I know you will. So in any case, from our side, stay tuned. We'll be in touch, as I mentioned. We're IATA is an organization. It's in its baby infancy stages, so we'll be in touch with you in terms of kind of next steps, more, the quote-unquote more formal stuff, membership criteria, and we can engage better, et cetera. So we'll be in touch with you. And finally, I want to also make mention, thanks my husband. I don't think he's here right this minute, but he is such the supporter and champion. Without him, I could not do this. Every time, I love him, and he's very special. So I want to thank him. And last but not least, dinner, food, right? I hope you can all stay and join us at the Dia Tafta Tavern. I don't know exactly where it is, but we're going to follow Chantal and the team to the venue. I think what we're going to do is meet in at 5:30? Is that in the lobby? Oh, there. Okay, sorry. I'm missing the obvious. Irina, go ahead. Thank you, Irina.